Congenital hypertrophic pyloric stenosis or SHIPS. This disease is the commonest cause in surgical practice for persistent vomiting during infancy. It occurs in one newly born in each 400 births. Usually it occurs in the first born infant, more in male. The incidence between male and female is 4:1 and may be familial. What is the etiology of this condition? The etiology of this condition normally there is nerve impulse passing in the wall of the gut and impulse passing in the stomach. When this nerve impulse passes to the stomach, it allows contraction of the wall of the stomach and relaxation of the sphincter. This impulse to pass freely to allow normal movement of the stomach and normal relaxation of the pyloric sphincter need mature ganglion cells in the nerve plexuses in the wall of the gut. This condition usually occurs due to immaturity of ganglion cells in this region, in the region of the pyloric sphincter. Therefore, this leads to the impulse pass in the stomach, but this impulse cannot reach probably to the sphincter, leading to failure or delayed relaxation of the sphincter. If there is failure of relaxation or delayed relaxation of the pyloric sphincter, this leads to pathology. What is the pathology? The pyloric canal, the muscles in the pyloric canal undergo hypertrophy of the circular muscle layer in the pyloric canal, and this hypertrophy leading to marked narrowing of the lumen of the pyloric canal and pyloric stenosis. This hypertrophy stops abruptly in the pyloric region, stop abruptly in the beginning of the duodenum, and this hypertrophy decreases gradually when we ascend upward towards the pyloric antrum. We all know that the stomach is divided into fundus, body, and pyloric region. The pyloric region consists of antrum and the pyloric canal, which is the narrowest part of the stomach, and the pyloric sphincter. Therefore, failure of relaxation or delayed relaxation of the pyloric sphincter, leading to hypertrophy of muscle layer in the pyloric canal and the narrowing of the lumen with pyloric stenosis. And the hypertrophy stops abruptly at the duodenum, at the beginning of the duodenum, and decrease gradually as we ascend upward toward the pyloric antrum. What happens in the proximal part of the stomach? First of all, the stomach proximally undergoes thickening and hypertrophy to attempt to bypass the obstruction, but later on failure of the stomach to bypass the obstruction with accumulation of gastric content leading to dilatation of the stomach. The intestine distal to the obstruction is normal, but no food reach the intestine. Therefore, the normal intestine distal to obstruction is empty and collapsed. What is the complication of congenital hypertrophic pyloric stenosis? The same complication as we said before in pyloric stenosis due to cicatrized duodenal ulcer. The patient suffer from repeated vomiting. This vomiting leading to loss of HCl. Loss of HCl leading to metabolic alkalosis and may predispose in severe cases to tetany. Due to electrolyte loss, loss of sodium, potassium, and calcium, leading to hyponatremia, hypokalemia, and hypocalcemia. Loss of fluid, leading to dehydration. And due to lack of feeding, lack of effective digestion and absorption, there is sure anemia and loss of weight. Due to repeated vomiting, respiratory complication occur due to inhalation of the vomitus. What is the clinical picture of congenital hypertrophic pyloric stenosis? The clinical picture of congenital hypertrophic pyloric stenosis, usually the patient is born normal without any problem until about the second to fourth of a week. After 2 weeks or 4 weeks from birth, the infant constantly crying. Why constantly crying? Due to two things: hyperperistalsis in the stomach in attempt to bypass the obstruction leading to constant colic, and always the patient vomit. The stomach is empty, leading to severe hunger. Therefore, due to colic pain and hunger, the patient always cry. The main presentation of this disease is repeated vomiting, which is the most important prominent feature. The vomiting is repeated and projectile vomiting. Why? There is hyperperistalsis to attempt to push the gastric content against the obstruction distally to the intestine. If this hyperperistalsis fail, antiperistalsis in the stomach leading to expulsion of gastric content in the form of projectile vomiting. And the vomitus is never bile stained because it is a pyloric stenosis. If the bile below the obstruction can pass to the stomach, there is no pyloric stenosis. Therefore, we always vomit only gastric content, which is never containing bile and never bile stained. If there is bile stained vomiting, this indicate vomiting of duodenal content, which is due to another cause other than pyloric stenosis, like duodenal atresia, intestinal obstruction, etc. And the vomitus has offensive odor because stagnation of the gastric content for long time with fermentation leading to vomitus of foods of previous meals and offensive. There is repeated vomiting, and on the other hand, no food pass to the intestine. This leads to progressive constipation, and the minimal food pass to the intestine. The fluid from this food will be absorbed, leaving a small, rapid stool with decreased urination. The constipation is progressive and the stool is very small, very hard, like the stool of a rabbit. And there is, due to dehydration, there is also decreased urination. The patient usually present also by manifestation of complication like dehydration, loss of weight, anemia, and we should take care that loss of weight and anemia with dehydration is a feature of this condition because it is long-standing case, and no feeding, no weight gain, no formation of blood elements leading to anemia and loss of weight. The second pyloric region. The second pyloric region can be felt in about 90% of cases as olive oval firm mass at the level of L1 vertebra just to the right side of the middle line. What is this level of L1 vertebra just to the right side of the middle line? This is the surface anatomy of the pyloric region. During examination, there is epigastric fullness and visible peristalsis from left to right. And here, just to the right side of the middle line at the level of L1, the olive mass can be felt. In about 10% of cases, complication may occur as gastritis or esophagitis, leading to hematemesis. We should notice that any newly born presenting with projectile repeated vomiting and the vomitus is non-bile stained and continuous crying of the baby due to severe hunger and firm small stool should be considered as congenital hypertrophic pyloric stenosis until proved otherwise. Therefore, projectile vomiting, continuous crying due to hunger and colic pain, with also loss of weight and anemia, should be considered as SHIPS until proved otherwise. What is the differential diagnosis of SHIPS? Other causes of repeated vomiting in newly born, which is very common in gastroenteritis or overfeeding, congenital duodenal atresia, and the other causes of GIT obstruction as volvulus neonatura, intussusception, pylorospasm, antral web leading to gastric obstruction, and intracranial hemorrhage during birth. What is the investigations needed? The investigations needed, first of all, blood chemistry, show fluid and electrolyte imbalance, a very high hematocrit, hypochloremic, hyponatremia, hypokalemia, alkalosis, and GIT suction by bile tube show excessive amount of fluid. Imaging by ultrasound or X-ray is not needed if there is olive firm mass is felt. But if there is no olive firm mass is felt, we should perform ultrasound, which is the most important imaging modality in this case. Ultrasonic view to this patient show the thickness of the wall of the pyloric region. If the thickness of the pyloric canal is more than 16 millimeter, this is diagnostic. this is diagnostic for congenital hypertrophic pyloric stenosis. Sorry, if the thickness is more than 4 millimeter is diagnostic, and the length of the pyloric canal, this is the thickness of the pyloric canal more than 4 millimeter, and the length of the pyloric canal is more than 16 millimeter, this is diagnostic. Rarely barium meal or Belen X-ray will show, this is Belen X-ray, show dilated, markedly dilated stomach full of gases. Or rarely we need barium meal. What is seen in barium meal? First of all, narrowing or complete obstruction of the pyloric canal. And the narrowing of the pyloric canal, very thin line of barium pus. If very thin line of barium pus like this is called a string sign. A string sign. The barium is a white line like the string. And sure, there is proximal gastric dilatation. And there is shouldering, obstruction with shouldering. This is dilated stomach and suddenly obstruction here like this shoulder, therefore it's called shouldering sign. And there is double or triple track sign. What is the double or triple track sign? 2 or 3 white line appear. Very thin white line. Here there is 2 lines appear. Here there is 2 lines appear. What is this? This is indicate more and more severe obstruction. More and more severe obstruction, and the lumen is nearly completely obstructed. But the barium can pass between the mucosal folds. Barium can pass between the mucosal folds, leading to 2 or 3 white lines appear. And there is a string sign, very narrow pyloric canal. And when the barium reach the duodenum is wide. Very narrow pyloric canal with wide first part of duodenum, like what? Like this. This is mushroom sign. This is a string, very narrow pyloric canal and dilated, and barium in the first part of the duodenum appear dilated. Therefore, this is mushroom sign. Finally, there is hyperperistalsis above the obstruction. Hyperperistalsis above the obstruction can be seen. These are the peristalsis above the obstruction. Like what? Like movement of this insect. Caterpillar sign. Caterpillar sign, the movement of this animal, like the hyperperistalsis above the obstruction. This is called caterpillar sign. What is treatment of this condition? Only surgical, after rapid preoperative preparation. As any GIT obstruction and any pyloric stenosis, intravenous fluid, correct electrolyte imbalance, nasogastric suction and gastric wash, and treatment of respiratory complication and infection. Exposure of this patient may be laparoscopic or by Ramsted's operation. Ramsted's operation, we expose the second pyloric region by right upper quadrant transverse incision. This is the right upper quadrant, just to the right side of the middle line over the surface anatomy of the pyloric region at the level of L1, just to the right side of the middle line. We perform a transverse incision in the right upper quadrant, and we expose the second pyloric region. Once we reach the second pyloric region, the operation is pyloromyotomy. Pyloromyotomy incision in the thick circular muscle layer in the pyloric region, and the incision is longitudinal incision. The incision takes all layers of the stomach except the mucosa. Stop in the submucosa to avoid injury of the mucosa. This is very clear here in laparoscopic technique. Longitudinal incision in the second pyloric muscle, stopping at the mucosa, which will bulge, allowing dilatation of the lumen of the pyloric canal and the passage of any food reach. This is called pyloromyotomy. Otomy means incision. Pyloric canal. Myo, division of the muscle layer only. Myotomy. Pyloromyotomy. Okay, which may be laparoscopic or by Ramsted's operation. Thank you for good listening and good luck.